as we get into a final conversation, it's a hope that we will have a conversation with the Ministry of Health in terms of what Mpox is and the guidelines that are then being set by the Ministry of Health across board, and some of these vaccination protocols and questions that are already being asked. Before we have that conversation, just getting into a number of things here, let me remind you about today's proverb, and maybe I should give Jesse an opportunity to tell us what that proverb means to you today. No, before our guest actually sits down, but we'll do that all of us together. All right, so we are having a conversation about Mpox, what is going on, the state of health in Kenya in general, and our guest is seated here for this hour, and we'll be having that conversation with him. Dr. Sultani Matendechero, I will not butcher your name, I hope. The Deputy Director General of Health, State Department of Public Health and Professional Standards, is here with us this morning. Dr. good morning.
Good morning. Very good to have you here. Yeah, thank you for having me.
You're in the hot seat of the Situation Room.
Okay.
We'll be discussing a hot topic today, obviously, because it's starting to take many countries by storm. And we've seen cases of some in Kenya already, and already under, warning to be very careful about the information that we spread or that we put out there. But before we get into all of that, I want to welcome you in proper Situation Room style, and the way in which we do. Siti Muga, who is normally here, goes around the country, however you choose to, rather around the continent. However you choose to imagine that he does that every week and goes to a different country, we leave that to your imagination. But he does come back every Monday with proverbs from a particular African country. And then from each country, he gives us proverbs every day of the week. Your job when you come into the hot seat is to hear the proverb, tell us what you think about it and how you would interpret it. I will be Situ Muga for the next 1 minute, and then you can tell us what you think about it. Does that sound all right?
Sounds good.
All right. So this is a proverb from Côte d'Ivoire, formerly known as Ivory Coast, but they decided to use the French name. The proverb goes like this: you should not be frightened by a python because of its length. You should not be frightened by a python because of its length. What do you think about that, Dr.
I think what comes to mind immediately I hear that proverb is the other one, which says, don't judge a book by its cover. Yeah, so the outlook can be deceiving. Yeah, so you really need to take time to be able to analyze a situation before you can jump to conclusions about it. Yeah,
it's spoken like a doctor who might know a thing or two about the imminent threats of a viral disease. So yeah, I guess, and that's the thing about proverbs, right? That you can interpret them as you understand them, and it's that it's not right or wrong. It's how then it appeals or how you interpret it. Okay, so thank you for being here this morning. Over the last few weeks, external news reached us about Mpox. Some of that from the Western Hemisphere is Northern Hemisphere, interestingly enough. And then we started to hear news of it from Africa. And then if we look at the projection from Western African nations, one or two of them, to some Central African countries, and then now seeping into Eastern Africa, and a few dots here and there around Southern Africa. We don't know exactly what is happening. It has not swept the way COVID did between 2019 into 2020. But just an overview from you, Dr. Let's start from what Mpox is as a disease. What are we looking at? And before we start to look at its spread and then what's being done, what is Mpox? Okay.
Yeah, so generally Mpox is a viral disease. Yeah, it is caused by a virus. And this virus is called the Mpox virus. Remember, Mpox is a newer version of the previous name, which is monkeypox.
Yes.
Yeah, but we do not use that name anymore, because when it was discovered that when it is used, then it provokes a lot of stigma. Yeah, so it is now just known as Mpox. Now, this virus there are quite a number. It's related to a virus that used to cause smallpox. I think you've heard of smallpox.
Yes.
Which I think a lot has been done in terms of eliminating it. Yeah, but it is actually a virus that is transmitted from animals to human beings. And this is done when human beings come in contact with the blood or bodily fluids of those animals, or maybe lesions like wounds, either on the skin or on the mucosa, the internal linings of the body.
Yes.
So when they come into contact in that form, then they can be able to get infected by Mpox virus. And then when it gets into humans, again, it is possible to transmit from human to human. So maybe just in a nutshell, when you get that infection with Mpox virus, then it manifests in certain ways. So you'll see people starting to complain of fever. Mostly they will have a lot of fever, and then some will complain of headache, muscle pain, general body pains, back pain, and sometimes you'll even see the swelling of the lymph nodes, and generally at the end now, the classical feature is that they start developing body rashes, which start as some kind of macules. They become bigger, they become papules, then what we call vesicles, and then eventually they dry up, they form crusts. They can actually even form some small pustules with pus inside, and then they dry up, they form crusts, and then they drop off and leave a scar. So they form something like a scab, and then they drop. But one of the classical things is that they start with the face, and then they spread now to other parts of the body, the neck, the back, the chest, like that, the private parts, up to even the legs. Yes.
Is it curable? I mean, a lot of it has been likened to, what we saw with Ebola, and then after the serious hemorrhage, the likelihood of survival was then slim to none. With Mpox, are we looking at, with proper care treatment, that you can actually recover and get back onto health with it?
Yeah, so Mpox is one of these infections which really don't benefit a lot from treatment. They are self-limiting,
you treat the
like
symptoms?
many other viral diseases. But because of the symptoms that I have just listed, most of the people who are infected will benefit from what we call, supportive care or treatment. So if somebody is having, say, headache, then you can be able to handle that just in the conventional way. If they are having, say, muscle pain, then you can be able to handle that. And even the rashes can also be handled. But then the virus itself is self-limiting. So it will take between 5 to 21 days for the virus to show. And then after that, it just clears, the body clears it off. Yeah, but then in terms of severity, we would not have been worried. Remember, this monkeypox is related very closely to other types of pox virus infections. When we were young, we used to suffer from, there was a very common similar infection called chickenpox. Yeah, which I think probably most of us got. And, it might not have been very severe, but what we are seeing with Mpox is that there are several strains of Mpox. And because of the strains and also the vulnerability of the individuals who are infected, then you'll find that now we are seeing that it is killing. There is a case fatality of up to 10%. So that
my goodness,
yeah, not depending on the strain and the vulnerability. So you'll find probably people who are immunosuppressed, like people who have HIV infection. And probably it has manifested as autoimmune disease. They will be able to suffer more than people who are better, who have better immunity. Children, small children with the small, less immunity will suffer more. So you can see that among the vulnerable groups, we are seeing case fatalities of up to 10%, which is quite high. Not as high as Ebola and the other public health emergencies that we have seen, but significantly high for us to be able to look at it as a public health emergency of quite significant concern.
Okay.
Yes.
And I mean, I know it is one that we've seen now a number of cases in Kenya. What are we talking about now in terms of preventive care? Yeah,
so the preventive approaches are classical. They are standard. So you'll find that this is, as I said, it is a virus that is transmitted because of contact. So if you come into contact, then you get infected. So the primary intervention in terms of prevention is to avoid close contact. And especially when somebody is displaying the symptoms, then you actually now avoid. You don't come into very close contact with such people. And then, of course, we can also ensure that even when we come into contact with such people, cases or suspected cases, then we also observe hygiene. It really helps to ensure that you frequently wash your hands.
Yes.
It is also transmitted. One of the strains that is now affecting Kenya, because we call them clades. So the clade that we are seeing in Kenya, which is clade 1B, it also has a way of being transmitted through droplet infection, so respiratory droplet. If you come into very close contact with somebody who has Mpox and probably they sneeze or they cough, then it is possible for you to get infected. However, one of the things that I'm seeing is everybody is really struggling to compare Mpox with the COVID. We are still struggling with the post-COVID trauma. So everybody is wondering, why is it that you are not declaring the cases? Why are you hiding cases? We are not telling us about the case. But the fact is that this one does not spread as fast as COVID, because you see, COVID is a different kind of virus, which when you are in a room, it spreads much easier. The spread is much easier than Mpox. So we know that there are different dynamics, but then we are seeing that already in Kenya we have confirmed 4 cases. We are expecting that the number will go a bit higher, because the cases that we have confirmed are imported cases. Now the world is a global village. So people travel from all over the world. The hotbed of Mpox now is the Democratic Republic of Congo.
These poor guys, man. I mean,
where we...
It's not the same. Ebola was a big deal here as well.
Actually, the Democratic Republic of Congo is a hotbed of very many public health problems. Ebola, you'll hear of Marburg, you'll hear most of these diseases, because of the instability in the country and the effect that it has on the public health system. So because of the long distance, trade and truckers moving from Kenya to Congo through Uganda and so on, then they are coming in.
So the 4 cases that were found, sorry, Dr. the 4 cases, what we saw is that they came as a result of this long travel that you talk about. It was not restive in the country, whereby in community you saw infection. It was having been traced that somebody was on a long trip out of country.
Actually 3 of them.
3 of the 4.
3 of them, there's a very clear history. They are truckers, they are truck drivers. And you see that they were in Uganda, they were in Congo, so they are imported cases. But what we expect in such a situation is that after some time, when you have those imported cases and they come and start interacting with people, then we expect to see what we call community transmission.
Right.
Where now they start infecting people within the community. The third case, we do not have a very clear history of travel to the Congo, because this is a lady who was diagnosed here in Westlands, in Nairobi. And, when you look at her history, she has never gone to the Congo, but she had, after she had developed the symptoms, she went to Uganda. So when you look at something that we call temporality, you find that the symptoms came before going to the suspected area, endemic area. So you cannot really link the infection to that travel. So probably we could be already having some community transmission, but then we need to do much more to determine that.
Well, in a bid to curb community infection, as you put it, let's talk about the contact tracing, the steps that have been put in place by the Ministry of Health to ensure that these 4 individuals who have contracted Mpox in Kenya so far, that those they came in contact with are easily traced and monitored in order to avert an already, a worse situation. Talk to us about that.
So you didn't tell me your name.
Jesse Rogers.
Jesse Rogers. Okay, so Jesse, what happens is that we have a very elaborate mechanism in place, which is a surveillance system. When we deal with such conditions. And everything actually works like clockwork. It depends, one step depends on the other. So what happens is that we have disease surveillance officers across the whole country. So we have county disease surveillance teams, sub-county disease surveillance teams everywhere. So what we do when there is such a situation, we now give them a case definition. So we explain to them, we tell them, these are the signs and symptoms, but for this particular disease, these are the situation, these are the signs you need to really look out for.
Okay.
And then we try to now talk to the public, especially now like what we are doing, so that we tell them, these are the signs and symptoms of Mpox. So if you feel this way, go to a health center or a health facility or report to these numbers. Yeah, so we give out certain numbers which they can be able to call. Some of them are toll free. So when they do that, then we have a case report. You know, when somebody says, I have seen somebody with these symptoms, or maybe I feel what we were told, and I think I could be having Mpox, that is a case report. Now, wherever that case report is received, most of the time we receive it here at headquarters, then we alert the surveillance team on the ground. So the surveillance team, within 24 hours, are supposed to have already reached that case.
Okay.
Now, when they reach that case, they now check, they actually they examine the case, and then if they fit the case definition, they isolate the case immediately, so that this case does not continue spreading. If it is a confirmed case, they don't continue spreading the disease. Now, in the meantime, they pick a sample. From this guy. So they pick a sample. If they already have those lesions that we were talking about, they will pick some exudate from the lesion, and then we have...
What is exudate in English?
Those two fluids that, you know, if you have suffered from chickenpox, you know, it has some fluid inside. So they'll pick that, or maybe the crust, depending on the stage where it has reached. Then we have state-of-the-art equipment which we use to transport the samples, because these people who are also dealing with the case are at risk. So they have to really have protective gear, and then they have triple cased containers which they put in, sterilized. They put in the samples, and then they bring to the National Public Health Laboratories. Now, in the meantime, as we are now trying to confirm the case, we will now be able to start contact tracing. So we start asking this person, who did you come into close contact with? You know, so of course now, for example, the close family members are immediate contacts, so we start following them up, and then now we start tracing them, just to be able to see if they are going to develop the signs and symptoms. But in the meantime, we also encourage them, because your contacts, there's a very high chance that you might have gotten the infection, so you need to try and avoid coming into contact with other people, so that you don't infect them. So that's a community issue, obviously. By the time you're getting to the point where you start to ask questions, and then those who may have come in contact with, looking at interventions, the Ministry of Health has a program, that we've heard of, and I want to know if it is connected with this in any way, or certain interventions that would come into place, and that's the Epuka Uchafu ya nyumbani. What exactly is that? What program how does this program work, essentially? And are we looking at the same interventions that can take place when you're now starting to talk to communities about health issues? If you could just give some insight into that. So Epuka Uchafu is one of the masterpiece kind of programs that we are coming up with at the State Department for Public Health and Professional Standards. Because, we have this age-old thing of saying prevention is better than cure. But we don't practice it.
The prevention.
Now, let me surprise you. Science has shown that for every 1 shilling that we invest, or $1, I like using shillings because that's what we have here. For every shilling you invest in disease prevention and health promotion, you save a whooping 9 shillings that would have gone into treatment, rehabilitation, and palliative care. But you see, our systems are designed such that we start picking up issues when they require treatment. So we are spending a whole 9 shillings where we would have spent one bob. So just imagine, when you now put it to scale, the budget for the health sector, put it at even just 300 billion. If you are to save 90% of that budget that goes to treatment, what would you do with that money? How many schools would you build? So Epuka Uchafu is just looking at being able to now put our money where the mouth is. I don't know if I've said it correct.
Exactly.
Because sometimes I say it opposite.
I think a lot of things are done in the opposite. Put the mouth where the money is. But okay.
So what we are doing now, we are walking the talk. We are saying that make sure your environment is clean. You know, if you have dirt in the house, clean. If you have dirt outside, sweep. Make sure that your environment is clean. Make sure there is no stagnant water. You know, those kind of things. Believe me, when the community does that, it might look very small, but at a public health scale, it is massive. So that is what we are now trying to roll out. The initial investment might look a bit high, but once you have started, the downstream return on investment is extraordinary. So it is just about cleaning your surroundings, making sure that your water is clean, making sure that you are observing hygiene. For example, now when we say Epuka Uchafu, we are saying that make sure you wash your hands frequently. Now look at Mpox. We are saying one of the interventions to ensure prevention is to
wash your hands.
Yeah, frequent hand washing. So with Epuka Uchafu, we want to ensure that we give the tools, to the community members that can enable them to observe hygiene and sanitation, environmental sanitation. So the brooms, the dust bins, the water, all those things and the information that they need.
Yes. Dr. Sultani Matendechero is our guest this hour, and we're looking at, Epuka Uchafu at this point is a campaign that is being established, is being rolled out by the Ministry of Health, particularly from the Department of Public Health and Professional Standards. We already told us what it is. Looking at communities, it doesn't. I'm imagining that it's a strategy that would work across diseases. I mean, for lack of a better explanation, that if you do certain things, that when one does come along, that you're already then well placed to be able to deal with it, right? What strategies are you using to be able to roll this out, Dr. Harry?
Yeah, so I think I really like the way you're breaking it down, because what is amazing about this strategy or this program is how unbelievable it is in terms of its simplicity, in terms of its, affordability, but then in terms of the massive impact that it has, on the population. I was just looking at, I saw a copy of the Constitution here.
Yes.
And I was looking at the 4th schedule of the Constitution, which really envisions some of the things that we need to do as national government and as county governments. So when you look at Schedule 4, Part 1, it actually describes some of the roles that we should play as national government, which is health policy. So the first thing that we are trying to do is to ensure that we put the policies in place that can now enable us to roll out this program. But then at the same time, the same constitution also provides number 32, capacity building and technical assistance to the counties. So it is not something that we can do as a national government only. It is something that we have to. Even the constitution now ensures that we have to do it together with the counties. Yeah, because the counties, when it comes to their part, that is part 2 of that schedule. If you look at number 2, which is county health services, part C is promotion of primary health care. Now, primary health care can be divided into 2 big portions, which I was talking about: disease prevention and health promotion. So health promotion is what we are doing now when we talk to the communities. We are making them aware of what they can do so that they avoid falling sick. They prevent disease. Because they cannot do it if they don't know. So that is now something that we need to work very closely with the counties to ensure that the community members are properly empowered with knowledge, skills, and attitudes to be able to prevent sickness. And this one, as you correctly said, 100%, it cuts across. So one intervention will now be able to touch very many diseases. For example, if you ensure that your rivers are clean, like here in Nairobi, when you see the rivers, they really look pathetic. But if you ensure that they are clean, then you will have already dealt with quite a number of waterborne diseases.
Indeed.
Not just cholera, but even now, one of the number one, the top ailments we are seeing in our public health facilities is, diarrheal diseases, especially among children, So we will be able to cut down on those top-ranking diseases.
Okay.
Now, another thing you see, even when you look at this constitution, is still under number 2 for the counties, Part E, refuse removal, refuse dumps, and solid waste disposal. So how are we disposing our waste? How are we disposing, say, our sewage, for example? Because a lot of the diseases that we see are fecal-oral. They are transmitted through poor handling of our own human waste.
Yes.
So how do we do that? Solid waste, this usual this usual dirt that we have in the compound. How are we handling it? So it is something that we are now packaging, and a very important approach that we are using is to go out. Like a few weeks ago, 2 weeks ago, we were in West Pokot working with the county, the West Pokot County government, to be able to now work, clean their markets and so on. And we intend to be going to several places in the country just to ensure that as we do it together, they pick up the concepts and the attitudes and they are able to proceed with it.
Yeah.
Yes.
Okay, Dr. Ari, and I think the next question would be the money question, the affordability question, and it would be proper to note who exactly is financing the campaign, what partners are on board to ensure that this campaign is a success, and equally the strategies the ministry or the department will use to get more resources in order to actualize the goal that you want to realize. Yeah.
Now, I think this is one of the best interviews I've ever attended because you're asking very good questions. Yeah, I have not had such good questions in a very long time. Now, Epuka Uchafu, Afya Nyumbani, that's the full name of the campaign. It is now something that puts all these theories into practice. Number one, you cannot achieve public health outcomes as a standalone sector. It's not possible. Even when you look at the definition of public health by the World Health Organization, it actually tells you that it needs everybody to participate.
Right.
It actually tells you that you need not just the health sector, but you need all the other sectors, water sector, the national treasury, the environment, the ministry in charge of environment, the ministry in charge of livestock. All those sectors are involved. Number two, we cannot also just work on it as the public health sector alone, or maybe the public sector alone. We also need the private sector. The private sector has to come in. So we are working with the private sector partners across board. World Health Organization, World Food Program, all those, the equivalent for animal health, all those partners, Kenya Red Cross, AMREF, all the partners that are there, so that we now put them into some kind of whole of government, whole of society approach.
Right.
So what we are doing now is we are now removing that thought process of saying we as Ministry of Health, we as the State Department for Public Health and Professional Standard are rolling out Epuka Uchafu campaign. No. What we are doing, we are just making it possible for everybody to come and plug in.
Yes.
So that everybody can enjoy the savings that we are going to enjoy downstream, whether it is in the livestock sector, whether it is in the water sector, everywhere. Everybody has to participate. So we have a very organized mechanism of coordination for all these players to come in and participate. Now, we are using a PPP approach, a private-public partnerships approach. So private sector comes in, they invest in a way that they can also be able to make a return. The public sector also comes in and participates in a way that we are able to deliver services to the people. So it is a win-win-win situation.
Right.
Not just win-win, win-win-win.
Win-win-win.
Yeah, to everybody.
Okay, so that's interesting that you say that. So then at some point, will the public, and I think some of those questions pop up, will have to spend some money? Is there something that somebody's going to have to pay to be part of this campaign or to benefit from some of the things that the ministry then will be rolling out?
Yeah, of course, we need a budget. This is something that has to be financed, because we said for every shilling that we put in, we save 9. So we must have a budget for that shilling. And that's why we are saying that we really want to mobilize. We are coming up with very strong justification. Of course, in government, we have our mechanisms for being able to finance our programs. So we will be looking at all those sources of finance. We will be putting in a request. We have already done that to the Exchequer, so that we can also put in our share from the taxes that Kenyans are paying. But then at the same time, there is a budget that has been prepared where we are expecting that also the private sector will plug in. Now, as we talk about Ministry of Health requesting for resources from Exchequer, we are also expecting that even the other sectors, because they have a role to play, we'll also be looking at how they can also be able to fund their part. And then the private sector comes in so that we are able to finance the budget. Initially, it might look like a very big budget, yeah? But then downstream, you'll find that we will have cut down now the total budget in a manner that gives us a very big return, just as I said before. Yeah.
Okay. So, if we go back to giving a live example, for example, now with Mpox, it's 4 cases in Kenya, but it's an imminent threat, would you say? How would then Epuka Uchafu help to deal with the threat that Mpox could possibly pose in communities countrywide? So,
number one, Epuka Uchafu, first of all, encourages personal hygiene. So, as we said before, as people are observing personal hygiene, then they actually limit the transmission of Mpox. Because even if you came in contact with someone who has Mpox and you now wash your hands, properly under the Epuka Uchafu framework, you make sure that you have safe water, then you are able to prevent spread. Now, there's also an indirect benefit of this Epuka Uchafu, because it now provides a platform. In itself, as we are trying to roll it out, it provides a platform where we can also now leverage this platform to even enlighten the community much better. Even as we are implementing the interventions for Epuka Uchafu, we can also be able to ride on that platform to implement now specific interventions for the Mpox campaign. Remember, what we are doing now is we are actually doing something called preparedness. We are preparing ourselves. We can't wait for Mpox to now we start having 15,000 cases like DRC and 500 deaths before we can start running around to say what is happening. So what we are doing now, we are equipping ourselves. We are equipping ourselves with the PPEs, we are equipping ourselves with the tools that we need to ensure personal hygiene. So the Epuka Uchafu campaign becomes an excellent platform that can even help us in terms of preparedness for Mpox. So as the cases come, like now, I can assure you, Kenya is one of the best prepared countries in terms of dealing with Mpox. Yes, I sit on the Africa CDC's emergency consultative group, the one that advises the Director General. Like recently, when Africa CDC declared a public health emergency of continental security, we are the experts who advise, and you can be able to hear from the discussions to see what is happening in other countries. Actually, our surveillance system is one of the best that you can ever come across. So that preparedness that we are putting in place then really benefits from a campaign like the Epuka Uchafu campaign, because if we were to start from first principles, then we would not achieve as well a situation of preparedness as we would if we already have that platform.
So when you talk about surveillance system, I assume part and parcel, that means the screening that's happening at the border points, yeah?
That is part of it.
So I don't know, and I don't want to rain on your parade, because I've looked at the numbers, over 600,000 screened so far in terms of Mpox, those who are arriving in the country. But we have is it 3 cases who passed through the border points. So when you look at the efficacy of the screening, is it that these 3 people weren't screened, or the screening happened right before some of these symptoms rather were able to materialize? What exactly is happening there? And equally still on Mpox, briefly, vaccines seem to be the new, like there's so much clamor within African countries to get the vaccines. Are there any hindrances that we faced as a country so far in procuring the much needed vaccines?
Okay. So your question is very loaded and a very nice one as well. Number one, it is a whole continuum. You know, when we talk of surveillance, it's a whole continuum. So what we are trying to achieve is we want to prevent. Yeah, we want to prevent the occurrence of that disease. And then I talked of preparedness. So it is called PPRR. So prevention, preparedness, response, and recovery. So you'll find like COVID, once it was done, it ravaged our public health system. So we had to recover from it. So it is PPRR. Now, prevention is now one of the things you're talking about, screening. So you are trying to avoid cases from coming in. It is not a foolproof thing, you know. What you are just trying to do is to say, if we would have 100 cases just walking in, we want to reduce these cases to 0, to as close to 0 as possible. So even if we have maybe say about 10 or 20 or even 99, you know, we have achieved, you know, from 100 to 99. So what we are trying to do at this stage is to reduce. Okay. Then number 2, we are prepared. So we are envisaging that our prevention will not work 100%. We are hoping that it does. If it does, we will be very happy. Okay. But if it doesn't, then we will have prepared ourselves to deal with the cases that come. Remember, what we want to do is to prevent a situation where our public health system is getting overloaded. You know, that these guys are coming in many, and then there's a lot of community transmission happening. You saw that happening with COVID, where people would actually even die in the ambulances waiting for an ICU bed. So we don't want to see our public health system overwhelmed. So we try to reduce that. You know, we don't want to see a situation where, you remember, like with COVID, oxygen is not there, people have finished and so on. And people are dying because we are not prepared. So we are prepared for the cases that come in, we reduce them. Now, as we are prepared, as the cases come in, we respond like we are doing now. So immediately we get this guy, we are ready, we isolate, we respond. So that is the whole thing around, you know, surveillance, the surveillance system. We have a very good public health laboratory mechanism, so that immediately we suspect a case, we take the sample, we ship it to Nairobi, and within a very short time we have the results, and we can be able to intervene.
On vaccines, briefly.
So thank you about that. Now, vaccines, of course, you know that we, in our part of the world, we have a bit of a problem with vaccines. Currently in Africa, we have projected that we need about 10 million doses to be able to effectively contain the Mpox problem. But what is available now is just about 200,000 doses. So that is less than, that's about 2% of what we need. You know, so what is happening is that now at the Africa CDC level, we are now trying to identify which are the most critical areas, where the most vulnerable groups are, so that we start with those ones. But then as we continue mobilizing, because a lot of these vaccines will come from the global north. Like even these ones for Mpox, we are actually getting donations, which are coming in from the global north. Now, what we are expecting is that, and this is a conversation we've been having since the COVID time, is that we need to now develop our own capacity to manufacture our own vaccines in the global south, in the third world. And we are now making a lot of steps towards that. In Kenya, for example, we are pursuing accreditation. Our Pharmacy and Poisons Board, which is the regulatory body that oversees manufacturing of medicines, is now pursuing something that we call ML3. That is manufacturing level 3. status, so that now we can be able to, because vaccines are very, they are very delicate kind of medications, which if you don't prepare properly, you can cause a much bigger problem. Yeah, so they have to be very sterile. They are biological, some of them are biological, products. You are just weakening the virus so that you can help the body to produce antibodies. So if you don't do it well, you can actually even now cause the disease. Yes. You can cause a very big problem. So we have to attain the ML3 status, which will now enable us to have to gain the confidence of other countries. If we prepare the vaccine here, we can take it to other countries.
I think that's very interesting, that reaching that status that conversation seems to come up when there is a state of emergency. Is it something that can be achieved even when there's a hiatus?
Yes, that's what we are doing. Actually, it is a rigorous process. There, we've had teams coming in from Geneva to assess our facilities, and it involves looking at our labs, like the National Quality Control Laboratory, looking at our Pharmacy and Poisons Board, looking at generally the facilities across the country. And at first, we started off with more than 100 areas that we needed to correct. So we have been working on them during this hiatus that you're talking about, and now we are just at about 40, which we are expecting that within another maybe few months we should be able to do. Then we are given that. Now this is happening across the whole of Africa. Remember, the Africa Union actually created the Africa Medicines Agency, AMA, which is now it is stationed in Kigali. That is where it is situated. So this one is now kind of like a continental regulatory mechanism where we can now pool resources, and then we work with the economies of scale. So we conduct a very effective market shaping where we know if we start producing vaccines, we already have a market that is big enough to sustain this expensive venture, because we have more than 1.2 billion people in Africa. If we start a venture of producing vaccines, then we should not fail, because there is a big market. Now, when we get there, it will be much easier, because we are working alongside being able to manufacture. We are also working towards being able to build capacity of our institutions, to build capacity of our scientists, so that we can conduct research, we can be able to manufacture these vaccines in the future. But now we are depending on those donations.
I think it just does a cross-section of a thought where we deal with issues of vaccine hesitancy, especially over time, whereby we thought, with COVID, which usually is the one thing that we go back to, there was a lot of speculation in terms of who was manufacturing these vaccines. Big Pharma came into play, and was there a need for first, second, third, I don't know how many ever dose. But then when we are looking at vaccines, it has been proven, I don't even we're dealing with the scientific, that it is necessary in many cases for you to prevent the furthest onset of a disease by taking the vaccine. Now here we are, where we have diseases that, shake the world and take the world by storm, and then the whole political area or political conversation about vaccines and vaccination and getting Africa to the status. Do you think that now African countries with a status whereby you can now give or receive would then be able to deal with this issue of vaccine hesitancy? Because usually say, something coming from abroad, they're trying to neutralize us, they're trying to sterilize us, so we're not going to take this thing. But if it is coming from where you have the status to then manufacture your own, have your own protocols, do you think it would take care of that?
Yeah, so it takes us back to what we said before in terms of health promotion. We usually think that health promotion is a very easy thing. You just come to Spice and you talk about it, and then people will agree and continue. Now, public health is a very complicated thing. Actually, all of us are public health practitioners, including you, because everybody contributes to effective implementation of interventions. So we need to invest. That's why we are talking of that 1 shilling. We should not just look at it as something that is all talk. We need to invest in health promotion. What you are talking about in terms of vaccines is what the people who drive this narrative are called anti-vaxxers.
Yes.
Yeah. Now, these are just people who have their own, some of them really believe in what they are saying.
And some of them actually are anti-vaxxers by word, but they shoot.
They actually go for the vaccine. So there are some who really believe in what they are saying. You look at them, they believe that these things are bad, and that's what they have been made to understand. So you see, as public health practitioners, we also need to take that as a very important intervention. How do we reach these people so that we explain to them that and make them understand, change their mindset? It's actually called behavior change communication. We need to come up with mechanisms of being able to make them understand that these are life-saving interventions that we must be able to give. Now, remember, there are some issues that we also have to take in mind. For example, all medicines that you take, they have, that's why we call pharmacy and poisons.
Poisons, yes.
They have a potential to cause a problem. All of them. But what we end up looking at is, can we have something that is going to give us more benefit than risk at the end of the day?
Yes.
So what we strive for is a product that will give us 100% benefit and 0% risk.
Yeah.
But there is always the potential for risk. Now, before a medicine is released into the market, it undergoes rigorous, actually it is called clinical trials. You start with animals, then you go to human beings, you give them placebos, then you now go to, human beings, you give them small doses, you continue increasing as you look for any side effects. It's a very rigorous thing. By the time a vaccine is being released, it has undergone, perfect confirmation that it is safe for use and it is effective. Yeah, there are 4 things that are looked for. Safety is number 1.
Yeah.
Efficacy is number 2, because you want to give something that is going to work.
Yeah.
Then, of course, now there is access. Is it something that can be taken everywhere so that everybody can get? And then there is cost.
Yeah.
So when it comes to the anti-vaxxer issue, it is something that we really have to now tell people there could be some truth that there is a bit of a risk, some kind of side effect, which you will feel for some time. But the benefit is big. If we don't give this vaccine, the devastation will be
worse,
unimaginable,
Yes.
So we have to keep on looking at it that way. We cannot say that it is 100% safe, there will be no side effect, there is nothing. No. We have to say that we anticipate. And even the side effects don't happen in everyone. They could happen in some people and not in others.
Right.
They could be worse in some people and not others. And then if they happen in some people, then we have mechanisms of being able to intervene.
Yes.
There is a protocol
to take care of that.
There is pharmacovigilance, where we also check and see if there are any adverse drug reactions, or there are any side effects, serious ones, then we can be able to intervene. But at the end of the day, we have to look at it as a public health scale.
Indeed.
Yeah.
Dr. Sultani Matendechero, thank you so much for being here this morning. It was important that we have this conversation, even as speculation is rife. You've grounded a number of things for us this morning. Thank you very much, and we look forward to conversations in the future. Dr. Sultani Matendechero is the Deputy Director General of Health, State Department of Public Health and Professional Standards from the Ministry of Health. And that ends the Situation Room for this Tuesday morning.
This is the Situation Room, the only way to start your day.